Welcome to The Explainer. Today, we're diving straight into a high-stakes medical mystery. We're going to focus on the respiratory system and decode a condition that's honestly just as deceptive as it is dangerous. It's called bacterial tracheitis.
Picture this for a second. A child has the sniffles, maybe a slight cough. The classic hallmarks of a routine viral bug. But then, out of nowhere, things take a terrifying turn. What happens when that simple common cold suddenly morphs into a toxic airway emergency? I'm asking you this directly because the sheer speed of the disease we're looking at today demands absolute vigilance. We are definitely not talking about your average sore throat here.
Okay, let's dive into this. Just look at this tissue damage. What we're seeing is a direct look inside a highly inflamed, severely compromised airway. Look at that extreme swelling, the intense redness, and the incredibly narrow passage left for air to actually get through. When a patient's windpipe looks like this, every single breath is an exhausting, terrifying battle.
Make absolutely no mistake here. When we see an airway looking like that, we are dealing with a literal, life-threatening airway emergency. This is a scenario where time is absolutely of the essence. Literally, minutes matter. If medical pros don't catch the shift from a mild viral bug to this severe bacterial complication, the patient's airway can just close completely.
So here's our game plan for today to unravel this whole thing. 1. The culprits, the etiology. 2. Spotting the signs. 3. Securing a diagnosis. 4. The counteroffensive, which covers treatments and complications. And 5. The essential nursing interventions from our frontline guardians.
All right, Section 1, the culprits, etiology.
So who exactly are the microscopic villains turning a simple cough into a deadly blockage? Well, what's really fascinating and kind of scary is the sheer destructive power packed into these tiny clusters. You're looking at Staphylococcus aureus under a microscope. Along with group A beta hemolytic streptococci, S. aureus is the absolute main villain in this disease. These bacteria are basically opportunists. They sweep in right when the airway is already weakened and vulnerable.
Let's lay out exactly what these bacteria are up to. Bacterial tracheitis is an infection and inflammation of the trachea, your windpipe. Now, rarely, it pops up as a direct complication of viral croup, or sometimes after an endotracheal intubation. Basically, the bacteria strike the mucosal lining of the trachea. This causes massive swelling and these incredibly thick, pus-filled secretions that physically block the air from getting down into the lungs.
Moving on to Section 2. Spotting the signs, the sneak attack.
Because this disease is such a master of disguise early on, it essentially launches a sneak attack before blowing up. Check out this timeline. For the first 1 to 3 days, most kids just show symptoms of a totally standard viral respiratory infection. But then comes the sudden escalation. The patient spikes a high fever, develops this deep, barking, croup-like cough, and inspiratory stridor. That's that terrifying, high-pitched crowing sound when they try to breathe in. For some kids, this onset is crazy fast. They rapid fire into a critical phase with labored breathing, chest pain, and copious, purulent, meaning pus-filled, secretions clogging up the airway.
In this progression brilliantly illustrates the ultimate diagnostic trap for healthcare providers. Bacterial tracheitis looks so much like viral croup at first. A younger kid with a fever, that barking cough, the stridor. But the main differentiator, the massive glaring red flag, is that with this rapid progression, the patient quickly becomes what we call toxic appearing. They are in severe respiratory distress, they're lethargic, and they just look incredibly sick. It's an immediate drop-everything airway emergency.
Section 3. Securing a diagnosis.
Recognizing that a child looks toxic is step 1, sure. But confirming it takes some serious medical detective work. The diagnosis relies heavily on a strong clinical suspicion based on that toxic presentation. To confirm it, doctors might grab a lateral neck radiograph, basically an X-ray of the side of the neck. But honestly, direct laryngoscopy, which is physically looking down the airway with a camera, is the definitive way to see the inflammation and those thick secretions. But listen to this, because it's absolutely crucial. This procedure must be done under highly controlled circumstances. Why? Because messing with an inflamed airway can cause it to just spasm and clamp shut completely. So this scoping has to happen in an environment like an OR, where an artificial airway can be placed instantly if things go south.
Section 4. The counteroffensive, treatment and complications.
Once we've got the diagnosis, the medical team has to launch an immediate counterattack. Severe bacterial tracheitis has to be treated with the exact same urgency as epiglottitis. So the crucial point is this.
Step 1 is always, and I mean always, ensuring an adequate airway. Often, that means intubation, done by a highly trained pediatrician in a controlled setting. You secure that breathing tube first. Only then do you move to step 2, which is hitting it hard with broad-spectrum empiric antibiotics. We're talking IV vancomycin and ceftriaxone to cover both S. aureus and strep species. Finally, step 3. Once the lab cultures identify the specific bug we're dealing with, we narrow that antibiotic coverage down.
In the real world, this transition happens in 2 distinct phases. We start with aggressive, empiric IV meds, broad-spectrum antibiotics pumped directly into the bloodstream to slam the brakes on this rapidly spreading infection. Then, once the lab tells us exactly which specific bacteria we're fighting, the treatment evolves. We switch to highly specific, culture-based targeted therapies to finish the job safely and effectively.
And we have to be this aggressive because, frankly, the stakes are just astronomical. If treatment isn't fast and dead-on accurate, the complications of bacterial tracheitis are devastating. Patients can suffer massive drops in blood pressure leading to severe hypotension or even a full-blown cardiorespiratory arrest. The infection can easily spread down into the lungs, causing bronchopneumonia or systemic sepsis. And get this, even if the patient survives that initial acute phase, the prolonged intubation needed to keep them breathing can lead to subglottic stenosis, which is a dangerous scarring and narrowing of the airway right below the vocal cords.
Let's move to Section 5, the Frontline Guardians, Essential Nursing Interventions. Now, prescribing the antibiotics is only half the battle. The minute-to-minute survival of these kids really rests in the hands of the frontline heroes, the nursing staff. A nurse's role kicks off with incredibly vigilant assessment. They're digging into the patient's history, checking specifically for recent upper respiratory bugs or flu-like symptoms, and double-checking if they're vaccinated against influenza and pertussis. Physically, they're on high alert for that classic high fever, hoarseness, and that scary high-pitched inspiratory stridor. They're watching the chest and nose like a hawk for retractions and nasal flaring, which are those really subtle warning signs of labored breathing and impending respiratory failure. And of course, they are constantly monitoring those oxygen saturation levels, the SpO2. From there, it is all about hands-on airway management. Priority number 1, ensuring a patent airway and being totally prepped for emergency intubation and mechanical ventilation if the patient suddenly crashes. Nurses will physically sit the patient upright or semi-upright just to reduce the compression on the airway and make breathing even a tiny bit easier. They'll also give humidified oxygen through a mask or nasal cannula, because drying out those already damaged airways, that's a huge problem. And crucially, they are constantly monitoring for any altered mental status. Because think about it, a confused or lethargic patient is a patient whose brain is no longer getting the oxygen it needs.
Finally, there's the meticulous, supportive care and airway clearance. Nurses are giving antipyretics like acetaminophen to knock down that high fever and making sure the patient stays hydrated, often through an IV if they can't swallow properly. But here's the tricky part, dealing with those thick, mucopurulent secretions blocking up the trachea. Nurses have to suction them out, but it has to be exceedingly gentle. Aggressive suctioning? No way. That'll just further inflame that super delicate tracheal tissue. They'll also give nebulized bronchodilators like albuterol to help with the spasms, and nebulized saline to loosen up and clear out all that stubborn gunk.
Bacteriotracheitis is honestly a stark reminder of just how fast the human body can go from a routine illness right to the brink of disaster. The line between a manageable barking cough and a total, life-threatening airway obstruction is terrifyingly thin. So I'll leave you with this final thought. Whether you're a healthcare professional on the floor or just an informed caregiver at home, as a frontline guardian, are you prepared to recognize the sudden shift from a common cough to a toxic airway emergency? Thanks for joining me on this explainer, and please stay vigilant out there.